All right, welcome everyone. I want to thank you all for joining us today for the Road Health Careers webinar series. Today's webinar series is sponsored by UCSF Fresno and UC Merced. My name is Emmy Lopez Phillips, and I'm the Associate Director of the Latino Center at UCSF Fresno, and we're really excited to be here today to welcome Dr. Marina Roytman. I want to say that the goal of our webinar series is to strengthen the health careers pipeline and also to encourage students from the San Joaquin Valley to understand the importance of returning to serve our communities here in the Valley. And so we hope that through this inspiring session, you will see how important that really is. Today's session title is "Oh, the Places You'll Go." And I would just like to turn it over to Dr. Marina Roytman, who will be sharing um, all about her work today. Thank you very much for being here, Dr. Roytman.
Thank you, Amy, for the introduction. And thanks, guys, for joining me. Let's see. We are going to talk about hepatitis C today. But before we jump into the hepatitis C, I want to share a little bit about myself and how I got to be here and in front of the screen presenting to you all. So I was born in the former Soviet Union. This is a country that no longer exists. Some of you might be familiar with part of this country as Russia. When I was 16 years old, my parents came to America looking for a better future for me. So you are closer to 16 than I am. And you remember this is kind of a rough time, right? I mean, so I ended up in a new country, new school. I did not speak a word of English, and it was a little bit of a rough going. So a few months later, I did pick up the English, and school has gotten easier and things have stabilized to some extent. So as the time went on, I became more and more interested in medicine. I have always been interested in medicine. And coming to America was an interesting realization that it doesn't really matter, who you are and where you're starting. As long as you work hard enough, you can always find your place in medicine or in whatever it is that you're looking at. So I initially started working as a nurse's aide in a nursing home after high school. That took about I think it was like a 6-week training course, and you got a little diploma and you were a nurse's aide, and you could take care of the patients in a state-run nursing home, give them baths, get them dressed, get them fed. So I did that for about a year and realized that I am just not built for it. This work is really, really hard. It's very physical, and I did not think I could do it for the next 40 years. So I thought I would, try to find something a little bit less physical. So that led me to go to college, University of Hawaii. Eventually, I went to medical school at Oregon Health Sciences, became interested in internal medicine, did my residency and the rest of the training at Mount Sinai. I came here about 4 years ago at an invitation from Dr. Peterson. And the reason he invited me is because there was an opportunity to build a liver program from scratch. I love building things from scratch. And I jumped on this opportunity and I came here. And it's been really the most amazing, 3-4 years of my career, being able to teach really all learners from, high school to college to residency to fellows to, full-grown physicians, practice in a population that I really love, the underserved population, and really being involved in the community. So it's a small group. Feel free to jump in, ask me questions. Let's make it as interactive as we can within the Zoom constraints. I'm keeping an eye on the chat box. So if you want to type a question in the chat, you're welcome to, or unmute yourself and just jump right in. So today we're going to talk about hepatitis C. My lecture is based on Oh, the Places You'll Go by Dr. Seuss. which is one of my favorite books. So hepatitis C, when I first started training, which was not that long ago, was an uncurable disease. It was our worst fear when we were in medical school and residency that we were going to get stuck, during surgery or whatnot, and acquire hepatitis C, and then it will never be cured, and we will die from cirrhosis. So that's kind of how it started. And today we'll talk about, I'll tell you a story about how the hepatitis C has been conquered. Congratulations, today's your day. You're off to great places, you're off and away. So what are we going to learn today? We're going to review what does the liver do? What are the things that can cause damage to the liver? We'll learn more in depth about hepatitis C, who is at risk, how to diagnose, and can hepatitis C be cured? And you can see I'm giving you kind of a spoiler alert that hepatitis C indeed can be cured. So where's my liver? The liver is located under our right rib cage, and a normal healthy liver is about the size of the football, and it's completely hidden under the ribs. If your liver becomes infected or swollen or whatnot, it's going to stick out from under the ribs, and when the doctor examines you or examines the patient, they can feel the edge of the liver, which would kind of makes us think, hey, there's something wrong, we should try to figure out what is going on. Okay, so what does the liver do? Well, so I'm a liver specialist. I am clearly biased. I think it's the most important organ in the body. So it does two major things. Okay, so one, it's the body's factory. It makes proteins that helps our blood clot, right? So when we have a cut, we do not continue to bleed, but it forms a nice crust to help the body heal. It also makes the proteins that help the body to be nourished. Its other very important things is removing toxic substances from your body. So as we live, as we eat and breathe, the toxic substances are produced, and liver and kidneys are the two organs in charge of removing these substances from our bodies. So what can damage the liver? So certainly drinking alcohol, it's still the number one cause of liver damage. The second is viral hepatitis. So we're going to break down what it means. So in Latin, hepa means liver. Itis means inflammation. So hepatitis means inflammation of the liver, and can be lots of causes for inflammation of the liver. So if your liver damage comes from alcohol, this is called alcoholic or alcohol-related hepatitis, okay? So it's not necessarily an infection, but today we're going to focus on the infectious type of hepatitis. So there is a kind of an alphabet soup. We have many different types of viral hepatitis: A, B, C, D, and E. And today we're going to focus on C. The one thing I want to bring up to your attention is excess weight, being heavy, being unhealthy, lots of junk food, not a lot of exercise, can also lead to liver inflammation, hepatitis. And this is called fatty liver disease or steatohepatitis. And steatohepatitis means fat. So that's another cause of liver damage that is rising all across the industrialized world. So what happens if my liver is damaged? Okay, so initially the liver can get swollen. It can be felt below the ribs. More serious or long-term damage can lead to liver becoming scarring and to the liver scarring and then becoming small and hard, so shrinking. Okay, this is called cirrhosis. And when you hear the word cirrhosis, it means a lot of scarring. And similar to the hepatitis, itis, the cirrhosis you can get to cirrhosis from many different angles. So a lot of the times when patients come to see me in my clinic with a diagnosis of cirrhosis, they feel very ashamed because they think that cirrhosis only happens to people who drink. And I reassure patients, this is the first thing I do when the patients come to see me, that I know you're not a drinker. I know that the liver cirrhosis can be caused by other conditions. So it's very important to build a trust with a patient and to make them understand that this is not necessarily their fault. So what are the physical signs of liver disease? So when you go to medical school or nursing school or whatnot, there's a lot of attention being paid to physical exam. And we can learn a lot about the patient and their disease state without doing a single x-ray or drawing a single blood test. So patients' eyes turn yellow. This is called scleral icterus. People with severe liver disease lose muscle mass. So you can see how all the bones are sticking out in this patient's face. Patients develop this funny looking spider-like lesions. They're called spideangiomas. And this is a sign of advanced liver disease or liver cirrhosis. Patients develop something is called clubbing. So you can see the nails have kind of a rounded, odd shape. If you look at your own nails, your nails look different. And this is, again, the sign of liver dysfunction, also seen in advanced lung disease. Men develop breast, also known as gynecomastia. That's an imbalance of the hormones in patients with liver disease. This is patients develop veins in their abdomen. This is called caput medusa. We already talked about liver being felt below the ribs. Spleen, which is on the other side from the liver, can also become enlarged. People can build up lots of fluid inside their abdomen. This is called ascites. This is very uncomfortable and oftentimes requires us to put a drain to relieve the pressure. Okay. Now we're going to jump to hepatitis C. So hepatitis C is an RNA virus, right? We are hearing lots and lots about viruses on TV these days. What is interesting about the hepatitis C virus that is able to hijack our own cellular machinery. So it basically borrows the machinery from our cells, and from inside of our cells to make more of itself. So it's very sneaky. So I'd like to share with you that the Nobel Prize for Medicine this year went to the team that discovered hepatitis C. So this is Dr. Harvey Alter, and I met him. He is the coolest guy, and he writes poetry. He's a true Renaissance man, and I'm just so privileged to be able to know him. It was just that one time that you won the Nobel Prize, wasn't it, dear? This is just for fun. I couldn't resist putting that one in. So hepatitis C, we didn't know about it forever. It was first identified in 1989. We actually didn't know it was hepatitis C at that time. It was known as non-A, non-B hepatitis, post-transfusion hepatitis. We knew it happens to patients, who had a blood transfusion. So formally, the screening became available in 1992. The ways that we can get hepatitis is from blood to blood transmission, often blood transfusions, sharing needles, whatnot, sexually and vertically. Vertically means from mom to baby, okay? The incubation period, which means how long is it from the time you got infected to the time that you've had symptoms, can be anywhere between 60 and 90 days. There are 6 genotypes of the virus, so 6 subtypes, okay? Vaccine, another hot topic on the news, is not available and is unlikely to be available. So a little bit different from coronavirus. So all viruses mutate. Coronavirus mutates. And you guys hear all the talk about the variants and whatnot, right? HepC is a champion in mutation. It mutates so rapidly that we are at this point unable to lock on something that is stable enough in the virus to produce the vaccine. So vaccine is unfortunately not coming anytime soon for hepatitis C. So let's look at the liver. So this is the liver. So over here on this side, the liver looks nice and smooth and shiny. This is a healthy liver. It has no scarring. Scarring is fibrosis, okay? Hepatitis C can live in our bodies for a long time, right? Decades before it becomes, before we realize that it's there. As the virus stays in our body longer and longer, it causes damage to the liver. Initially, you have minimal scarring, then more scarring, then you have severe scarring, and then you get all the way to cirrhosis, which is a whole lot of scarring. Patients who have cirrhosis are at risk for developing liver cancer. Patients who have cirrhosis are also at risk for developing what we call decompensated cirrhosis. And this is the people who have liver scarring, but also a lot of things are not working right in them. Their blood doesn't clot properly. They have confusion because the liver isn't clearing out the toxins. They have fluid buildup. So this is all the signs and symptoms of decompensated cirrhosis. So how many chronic diseases can we cure? Well, if this was in person, I would call on you to tell me. But since it's not, I'll tell you that we can only cure one chronic liver disease. It is hepatitis C. The rest of the diseases we can manage. We can give people medications and extend their life and make them feel well, but we cannot cure them. So why is it that the hepatitis C can be cured and nothing else? So let's look at the HIV or AIDS, okay? So this is a cell. This is the nucleus inside of the cell. What happens in HIV is the viral genetic material integrates into our human genetic material. So the drugs cannot get to it, and therefore HIV cannot be cured. Similar for hepatitis B. The virus also integrates in our own genetic material, and it also forms this circular molecules called cccDNA molecules, which again, the drugs cannot get to. Therefore, hepatitis B cannot be cured. In hepatitis C, we got super lucky because the viral genetic material is hanging out in the cytoplasm. It's not in the nucleus. So the drugs can come in, kill the viral RNA, and you're cured. It doesn't hide anywhere. It hasn't integrated anywhere. So this can simply be cured. So what is cure? Okay. So let's look at this graph. I'll talk you through it. So here we have how much on the y-axis, how much virus we have. And on the x-axis, we have the time. So we're starting with lots of virus. We're going to give the medication to the patient, and the virus is going to drop rapidly to the undetectable range. So the patient is going to take the medication for about 8 to 12 weeks. And then we're going to wait another 12 weeks. And then we check the viral load again. If the virus is undetectable at that time, then it means that the patient has been cured. So how are we doing in the United States with the hepatitis C? So this slide is getting a little bit old, 2018, but 2020 has largely been kind of a bust for hepatitis C treatment because we were busy with COVID, right? So it's not going to look that dramatically different. So we have probably roughly 3 million and rising, which I'll explain to you on the next slides, of patients infected with hepatitis C. About 600,000 are aware of being diagnosed with their disease. This many, 5%, have been cured or treated, and the vast majority of them have been cured. But this gap between those that are even aware, let alone treated, is huge. So our goal is really to identify the patients who have an infection that they're not aware of. So a few years back, we thought that the majority of patients with hepatitis C infections were known as baby boomers. Baby boomers are probably your grandparents, parents at this point. Those are the ones that are born between 1945 and 1965. There was lots of things going on in those years, right? This was Vietnam War. This was a summer of love. So lots of reasons for why these patients potentially have a higher risk of having hepatitis C. So we can see on this graph that, the vast majority of people belong into that group. So we're like, okay, that's great. Let's just screen and treat this population group and we'll be done with hepatitis C, right? Well, not so fast. So this is what the graph looked like in 2007. So as predicted, this is your baby boomers, lots of them. However, in 2015, look at what is happening here. The young people, in their 20s and 30s, for some reason, are developing this crazy amounts of hepatitis C. What in the world is going on? Well, as some of you may be guessing correctly, this has to do with the opioid epidemic. right? It is an opioid epidemic that is driving the infection, the hepatitis C infection in younger patients. So among patients from 18 to 29, the Hep C infections increased by 400%. Among patients ages 30 to 39, they increased by 325%. I mean, these are just wild numbers. I mean, we have not seen anything like that happen before. Certainly, again, in the COVID world, the opioid pandemic is raging. People are continuing to engage in unsafe behaviors, and subsequently, the hepatitis C cases, new infections are still on the rise. So, what are we going to do about this? So, before, like I said, we were focusing on patients who were baby boomers. We're focusing on patients who had clear identifiable risk factors. Given this massive rise of infection in younger patients, CDC said, okay, forget it. Forget all the risk factors. Let's just screen everyone. Okay. So basically, all adults, whoops, what happened here? Excuse me. I apologize. I'm not sure what happened to my screen here. There we go. Okay. So the CDC said, let's just screen everyone one time. You remember that I mentioned that the hepatitis can be transmitted from mother to baby. Let's screen all the pregnant women each time they're pregnant. Okay. So now that we have this massive screening campaign going on, how do we diagnose? How do we screen patients? So the first step, you're going to check for hepatitis C antibody, and we'll talk in more details about it. The second step, if the hepatitis C antibody, we're going to look for hepatitis C RNA, the genetic material, as well as what type of hepatitis C the patient has. Then we're going to use something called vibration controlled transient elastography. This is kind of a mouthful, and we'll see how much scarring is in the liver and how urgently do we need to treat the patient. Okay, don't worry, we'll go over all of this in more detail. Okay, before the vibration controlled transient elastography is a new thing. Before that, we had to biopsy all the patients, stick a needle into the liver, take a small sample, see, in the lab how it is. So nowadays we no longer need to do that. So back to the antibody. So antibody is just footprints of the virus in your blood. It doesn't mean that the virus is there, but it means that the virus has been there before. Okay. If we see the footprints, then we're going to go looking to see if there's actual genetic material present. Okay. If the genetic material present, you have chronic hepatitis C. Okay. The viral load, it goes up and down, but it's really not as important as the fact that it's just present. So genotype. So genotypes are just different strains of the virus. Just like there's different strains of the humans, there's different strains of the virus. They all have similar effects on the liver. We can treat all of them. Genotype 3 is associated with fatty liver, and before it was more difficult to treat. Nowadays, we have medications that can treat all genotypes. So that has become significantly less important. I'll skip that, that's not important. So genotypes are very interestingly distributed around the world, okay? So let's look at the United States. We primarily have genotype 1. We have a little bit of 2s and 3s. Now, when we look at South Africa, we have primarily genotype 5. I've never seen genotype 5. When I look at Southeast Asia, I used to have a lot of patients from Vietnam that was predominantly genotype 6. But everywhere in the world, there's kind of a mix, except in Egypt, where we only see genotype 4. What in the world happened in Egypt? Egypt also has the highest prevalence of hepatitis C in the world. Well, what happened in Egypt goes back into the 1950s, into the epidemic of schistosomiasis. Schistosomiasis is caused by a parasitic flatworm. And it does lots of terrible things. It causes hepatic scarring, it causes kidney failure, infertility, bladder cancer, and it was an epidemic of schistosomiasis in Egypt. So you can treat the flatworms with this stuff called intravenous tartar emetic. It had to be administered through the vein, and each patient required 10 to 12 intravenous doses. So that was great, but the needles were not sterilized. They were using the same needles over and over and over again. And while they've gotten on top of the schistosomiasis, they've caused a massive, massive epidemic of hepatitis C that they're still struggling to contain to this day. So back to the vibration controlled transdental elastography, or VCTE. Okay, this is how we find out how scarred is a patient's liver. Okay, so this is a probe. It looks big, but it fits into the palm of my hand. And what it does is it sends a wave through the patient's liver. The wave bounces back and we can measure it. So let's think of the liver as a rubber ball, okay? If the rubber ball is nice and soft and squishy, the sound wave is going to take its time going through the rubber ball. If the rubber ball is hard as a rock, or like a cirrhotic liver, the sound wave is going to go a lot quicker. So we can correlate the speed of the sound wave travel to the degree of scarring of the liver. The faster the wave travels, the more scarring is present in the liver. Okay, so this is just a cartoon of how that happens. And then we have a nice table that correlates the speed of the sound wave travel to the degree of scarring. And we can tell if the patient has cirrhosis or if they have very little scarring in their liver without having to stick the needle in. Okay, so now that we've diagnosed our patients with hepatitis C, how do we treat it? You have brains in your head, you have feet in your shoes. You can steer yourself in any directions you choose. You're on your own and you know what you know, and you're the one who'll decide where to go. So we are going to be treating our patients, and we need to understand how to treat them and how did we get to this remarkable place of being able to treat these patients. So we are back into the early 90s. You remember that the hepatitis C was discovered in 1989, and the treatment became commercially available in the early 90s. So first we tried something called interferon. Interferon is a substance that actually your body produces and to fight infection, right? So when you're sick, when you're sick, you feel bad, right? You have a fever, you have muscle aches, you're just kind of not feeling so good. This is the effect of the interferon. So the thought was, let's give more interferon to the patients, and maybe this interferon can help fight the virus. So initially we tried interferon for 6 months. So these patients were feeling like they have a flu for 6 months. And we cured a glorious 6% of them. Not ideal, right? So then we said, okay, let's increase it to 12 months. Goody for us, 12 months of feeling like you have a flu, 16% cure. So basically, over a decade, we mocked around with interferon, did this and that and the third thing. And the most that we've ever gotten is curing patients maybe at a 50% rate. So nothing, not interesting. The side effects of interferon therapy are terrible. Flu-like symptoms, your bone marrow doesn't work, you get really depressed, it's just awful. The other medication caused anemia that was used with interferon. And really the worst thing was that interferon could cause your liver disease to get worse. So if you're already dealing with somebody with advanced liver disease, interferon is not a good choice. So now this is a complex slide. Don't be scared. I'll talk you through it. So this is a hepatocyte or a liver cell, okay? And this is the virus. The virus comes into the hepatocyte. It actually kind of swallows it up. Then it takes its coat off, it uncoats, and the genetic material comes out. Remember that the hepatitis C likes to hijack our own cellular machinery to make more of itself. So it spits out this thing called polyprotein. Polyprotein is a bunch of proteins strung together that are needed to make more virus. It cannot work as a polyprotein. It needs to be chopped in little pieces, okay? So the thought was, what if we target this little pieces of polyprotein? Perhaps we can interfere with making more of the virus. So we looked at this polyprotein, we looked at this polyprotein, and we looked, excuse me, pieces of the protein, and this one. So this is where the science was going, and in the about 2012, the first study with I'm going to go back for a second, with blocking this protein, then NS5B came out. And this drug was called sofosbuvir, and it suddenly gave us a 90% cure rate in 12 weeks. So this was a remarkable achievement, right? We went from being able to cure maybe 50% of patients with pretty serious side effects over a 12-month period to being able to cure most everyone in just 12 weeks. This was a different study that looked at different genotypes. Again, 97% cure rate, which is really remarkable. So this study is still contained interferon. This drug, sofosbuvir, had to go with an interferon. So we were still kind of stuck. Patients with bad cirrhosis, you could not treat them with this. Patients with kidney disease were interferon intolerant. Patients who had a transplant or were getting ready for transplant were not good candidates for the treatment. So what are we to do? So in the meantime, there was another drug called cimeprevir. So cimeprevir targeted this region of the polyprotein called NS3,4A protease. Nobody was really excited about this drug. It wasn't as potent as the sofosbuvir. It still had to be used with an interferon, so nobody was super excited about this. So then somebody really clever thought, hey, what if we combine those two? This is a pill and this is a pill. Let's just see what happens. So no interferon, and this brings us to a famous Cosmos study. Cosmos study combines sofosbuvir and cimeprevir, and I want you to only pay attention to this column over here, okay? Forget everything else. So what Cosmos study is famous for is the number of patients that were enrolled. It enrolled this arm a glorious of 14 patients. And normally the trials enroll like thousands of patients, right? This is how we're supposed to go. But this one enrolled 14. And lo and behold, 92% of these patients got cured with just this oral treatment. And they had very few side effects. So lots of hepatologists got super excited because at that time, we had lots of patients who are in our hands whose liver disease was getting worse. We couldn't help them. They were not ready. You cannot transplant everyone. So everybody started prescribing what's called off-label. So these drugs were approved by the FDA, but not together. So kind of in that unprecedented move, our parent organization, American Association for Study of Liver Diseases, supported us in using this off-label drug. So FDA caught up pretty quickly and says, yes, that's okay with us too, go ahead and do it. So this was a very successful combination. So since that combination worked, perhaps we can come up with more combinations, right? So we did that, and there's lots of combinations that are available now. So at this point, so we have this weaker drug, and I'm going to teach you how to recognize some of the names of the drugs. So this is NS3,4A protease inhibitor. It will always have Previr in it, in the name. The NS5A inhibitor will always have an Asvir in it. And NS5B, this is the strongest one, will always have the Buvir in it. So basically, you can just combine the things and see what happens, right? You do not want to combine the drugs of the same class. You want to combine them differently and come up with all kinds of different combinations. This is similar to what happened in the early days of HIV. So what happened is in the last 2 decades, or less than 2 decades, we went from a 6% cure rate with miserable side effect to just a pill a day that we're now able to cure patients with a 95% chance of cure with just 1 pill a day from 8 to 12 weeks. So this has been a remarkable achievement. So we cannot treat everybody right away, right? And the damage to some degree will still persist even after we cure the patients. So what can we do, right? What can we tell our patients to do? So we'll say no to alcohol, cigarettes, and marijuana. While marijuana is generally a benign drug, it does cause progression of liver disease in patients with hepatitis C. Avoid gaining excess weight. You remember that the fatty liver disease is a problem. Eat healthy. Avoid unnecessary dietary supplements. Those can also cause damage to the liver if used improperly. Get tested for HIV and hepatitis B. Combining different viruses together is going to cause your liver disease to progress more rapidly. Get vaccinated for hepatitis A, B, flu, pneumonia, and now for COVID-19. Our parent organization just came up with recommendations that all patients with liver disease should be given priority for vaccination for COVID-19 because they're more likely to get very sick from it. So how can the infected patients protect others? So we counsel all our patients not to share anything that has a potential of blood-to-blood transmission, right? Toothbrushes, when we brush our teeth, you can have microscopic bleeding similar to razors and nail clippers. So it's best to have your own set. If there's any bleeding, we counsel the patients to clean it up and cover your wounds to avoid exposing others. The good news that it is safe to hug, touch, and kiss your family and friends. You cannot transmit hepatitis C that way. It is also to share cups, plates, and utensils. As I'm looking at this slide, I'm like, wow, this is clearly a pre-COVID slide. So not okay in the COVID times, but okay once we come out of this. And what is really remarkable about being able to cure the patients is not only we get rid of the virus, but we allow the liver a chance to heal itself. So you can see over here, this is a liver biopsy before treatment, and the blue lines is the scarring. So you can see lots of scarring. This patient has significant scarring or cirrhosis. And then post-treatment, you can see that the blue stuff has gone away. The vast majority of it has gone away. So the liver, once we've took away the hepatitis C that was damaging the liver, it is able to rebuild itself. So this is remarkable. We can see that once we cure hepatitis C, patients who have achieved cure have lower rates of developing liver cancer, essentially will almost never need a liver transplant, and even all-cause mortality is improving. So even other things that are not liver-related will improve if you get rid of the hepatitis C. This is another remarkable slide that I want to share with you, and these are trends in transplantation, okay? So this is a trend of hepatitis C. So it was kind of people who needed transplant, right? So it's kind of bouncing up and down, and then whoa, it just goes down in 2014. This is where most patients were getting access for hepatitis C therapy. So the need for transplant in hepatitis C has gone down dramatically. The need for transplant for alcoholic liver disease continues to go up, as well as for fatty liver disease. So the best news is hepatitis C can be cured with a simple regimen of just pills in as little as 8 to 12 weeks. Our patients have a 98% chance of cure. Cure can stop progression of liver disease and allow liver to heal. So what have we learned? We learned hepatitis C is common. Only a fraction of patients are diagnosed and even fewer are treated. CDC recommends testing all patients over the age of 18, regardless of their risk factors. And hepatitis C can be cured in as little as 8 to 12 weeks. And this is just amazing, I think. And will you succeed? Yes, you will indeed. 98.75% guaranteed. You're off to great places. Today's your day. Your mountain is waiting, so get on your way. I'd like to acknowledge my mentor, Dr. Naoki Tsai, and Dr. Theodore Seuss Giesel, whose slides I used, or poetry I used. Thank you. I will stop sharing my screen.